Vanitha, good evening, ma'am. Sajid Kumar here.
Good evening. Thank you,
I'll just make you
Rajesh.
the host.
Good
Yes.
evening.
Yeah, I'll make you the host, ma'am.
Yeah.
Voilà.
I can see Dr. Yahya, Dr. Shweta.
Hello.
Good evening.
Good
Welcome,
evening.
Dr. Shweta.
Thank you.
Welcome, Dr. Yahya.
Good evening. Welcome, ma'am. How are you?
I'm fine. Thank you, Doctor. How are you? Nice meeting you. Nice
I'm
meeting you,
doing
Dr. Shweta.
I'm doing great. Thank you for asking.
Welcome, Dr. Akhtar.
Hello, hi, doctor.
Oh,
Good evening.
good evening. While we are waiting, we can chit chat among ourselves. The program is gonna be 30 minutes each for each talk, and followed by a short segment on focus class and Q&A sessions that will take it as far as it can go. Then uh, of course, there will be IAP dignitaries who will kickstart the event. They will be around. I hope to have them here. This is a format. Usually, we go for each pediatric subspecialty every month, and then we have a interaction of a local speaker and the uh, Indian IAP speaker, and to have an exchange of info and have the latest the know-how to be transmitted for the practicing pediatricians to keep them updated. This is the essence of the whole planning of the CME. Welcome, Dr. Mohammed.
Yeah, hi,
Dr. Mohammed
Tabarik.
Salman, hi, how are you?
I'm good. Dr.
Dr.
Yahya,
Mohammed
Assalamu
needs no
alaikum.
introduction. I think everybody in the panel knows him. Dr. Mohammed is, because Dr. Yahya, I was just giving an overview of what the CME is about while we are having time to get started. Dr. Mohammed, you can sit, have a few words in the meanwhile.
Yeah, thank you, Dr. Vanitha. Welcome, Dr. Yahya. Long time.
Welcome, sir.
I hope you are
Dr.
fine.
Shweta is also there.
I'm
Yeah,
doing
hi,
great.
hi.
Thank you for asking.
Dr. Sweta, hi, how are
Hello.
you? Good evening.
Good. Thank you
Yeah,
for having me on board.
yeah, it's our pleasure to have you with us today in our monthly webinar. It took a good, actually, it's a good achievement. We did this one for more than a year now, and it's a continuous educational activity done in collaboration between the American Mission Hospital and the the Indian Academy of Pediatric. It's starting as an just local cooperation, but now we are having speakers and audience from all the world. I think in the last webinars we have attendees from Iraq, Egypt, different countries from the Europe, also from USA. So I think it is an expanded educational activity in which we can sharing all the experience and knowledge between the professional and the pediatrician in all the world. And hopefully we try this year to try to have a conference in which we may get physical attendees plus the online once the situation is allowed us to conduct this conference in Bahrain or in any GCC country. Again, it is different subspecialties in pediatrics. So we move every month in one of the specialty. And this month will be go deep in neonatology and I'm sure Dr. Yahya and all his experience in neonatology and the other speaker also. So I think this combination will give us a good experience and sharing the knowledge between all the audience and the speakers. I think we are just waiting all the audience to
Just 5
join
more
us.
minutes. Yeah,
Yeah.
5 more minutes, doctor.
Still, there is more 5 minutes. Yeah.
So thank you for the invitation. So when Dr. Muhammad asked me to present, so I was thinking what I should do. They always telling me that you are 6 steps ahead of people. So I was thinking, should I present smart monitoring? Should I present auto doctor? Should I present interactive virtual learning? Should I talk about something coding? Should I talk about RIP, respiratory inductance, plethysm, something sophisticated? Then I said, oh, this looks like more pediatrics. So let me present something very common. So we always been exposed to situations where you want to do it, not to do it. Is this the right pathway? So I selected a few topics to do or not to do in a gray scenarios.
It seems very appropriate, doctor, because we are always in gray scenarios, and as pediatrician neonatologists, of course, the attenders will be neonatologists also. And this
I
seems
presented last month in an Iraqi conference. They asked me to present something special. So I present something called Noor. It's an AI that I invented. So Noor is using Python language and Speak 24 language. She is at the level of board certified specialist in all specialty. And she can see the visible light, the thermal light, the vibration, the sound. She can integrate with machines. She can see the thermal light, the RIP, the TIP. She can do 100 of calculations. So I present that topics, and everybody was opening the mouth. So I said, no, I'm not presenting these topics again.
so she. I noticed that.
Yeah, so Noor mean light in Arabic, and Noor is my daughter. So I was coding her, and for 12 months now, almost every day, 6 hours. That's why I'm not going to any conference anymore. And so I created 10,000 files, and I use Beautiful Soup and Scrappy Crawls to collect the data from internet. So it's been working. She's been working almost 24 hours for last 7 months to collect. We collected almost 1 million book right now. So, and it's like DeepSeek, but DeepSeek cost 50 million. ChatGPT cost billions. I'm doing it free. So I'm just enjoying it. So I present that topic.
Interesting.
And yeah, and no, everybody was opening the mouth actually. So I said,
It's
when
interesting.
Muhammad asked me, so should I
We would be
present more?
privileged to have some insight into that as
So
well.
should I
after
present
we
more?
finish.
So they will say this is a creepy person. So I decided to go a very simple topic, which is where you want to do or not to do in neonatology.
We can keep Noor for one day, full day. So
It's
we have
actually
time
online if you want to
go.
use it.
Yeah,
It's
we can. We
the
cannot
simple
take this
version
one
of it is
30
online.
with 30
You can
minutes.
chat with it.
With 30
with
minutes,
her.
we cannot. I think to explore all these things, I think we need one day. So we will move through this.
Yeah.
Good evening, Dr.
And
Yahya.
Vanitha, she have
Doctor.
also helped the focus. She's also focused on the point of care ultrasound. So I think you can bring this also together with the more.
But right now I'm
Today-
using, so I'm taking it further, the focus. I'm combining it with Noor now. So Noor can get because Noor can read 5 second clips. So each minute, if each second, 5 second clip. So each second about 25 to 35 frames. And then she can interpret and give you diagnosis. But also she's using heart
Image
rate, respiratory
interpretation
rate,
becomes
trend.
this
She's
is flawless
using,
interpretation.
yeah.
Yeah.
So
Today it could be an interesting session. We have a focus expert and a cardiologist. So to pitch in focus in this would be even more interesting. So let's see how
yeah.
the session evolves. Okay, I think
At
we
the,
have
Dr.
reached
At
the
the end
time.
of your
Good evening, Vanita ma'am. Good evening. Good evening,
Good
sir.
evening.
Good evening,
Good evening.
Doctor.
at the end
Welcome.
of your
So,
presentation, you can see you can say a few words. People will be interested in knowing more about your AI. At the end of your
yeah,
presentation, you can talk about that.
it will
So
be
just to
it will be
be
a privilege
prepared
to
for
have
the
you.
next sessions.
You already, yes, that's right.
So
You already
it's
gave us an
a little bit
overview.
too complicated because I use SNOMED, I use Patch, icons, Python language, React. So I think most of doctors are not aware. That was the complication, the vibration, the sound, the light, the vital signs, the physical output, the RIP, the TIP, the computer graphic imagery, so lots of things are combined together and
Yeah.
using my
But
own
I
AI.
think
So
the user interface part of it, maybe you have piqued our interest already. So when we finish the CME, a few words on that score would be interesting.
sure.
Thank you. I can see our time. It's time to get started. I can see Dr. Singaravelu here. Good evening, Dr. Singaravelu.
Good evening,
So,
ma'am. Good evening.
good evening.
Thank you, ma'am.
Thanks for your presence here, Doctor. So I'll just give a introductory foreword, which I already discussed for the panel, which was available around a few minutes ago. So I am Dr. Vanita, the IAP Bahrain president. I extend a warm welcome to all the participants. This is our third webinar for this year, 2026. For the participants who have been our regular visitors, they may be familiar with our format. We have a pediatric subspecialty every month, wherein two speakers from IAP and a local speaker. We have broadened our scope now. The local speaker is not just from Bahrain, from across GCC. Thanks to Dr. Mohammed Salman for championing this cause of picking speakers from different parts of GCC. So that said, this is the third webinar, and each time it's a specialty. Today's theme is neonatology, contemporary decision making. So that's how I could fit in the speakers for the neonatology indicated topics. So we have the first speaker who would be talking on PDA and eternal dilemma, and the second speaker who is just now giving us an overawing overview of what his content could be. That's Dr. Yahya Etabi. I welcome Dr. Athar, who is the moderator for the session. After the IAP dignitaries giving her some encouraging words, I cannot thank enough. The support from IAP has been incredible. We have ticked in more than a year successful monthly webinars. So I welcome Dr. Singaravelu to give some encouraging words before handing over the mic to Dr. Athar to start the session.
Thank you, ma'am. Our
Dr.
president has joined. Madam, our president Neelam has joined. Let her talk first, then I will talk. Over
Okay,
to Neelam.
sorry.
Madam, welcome, Neelam.
Dr.
Sure.
Neelam,
Yeah, thank you.
as
I joined
always,
earlier. I
highly
think my
encouraging.
camera was not on. So maybe I
Yes,
was
I don't
not
see you.
being seen. I heard
Welcome,
you.
Dr. Neelam.
Thank you.
Let
No,
me
no, that's
introduce
okay.
Dr.
Thank you,
Neelam.
Anita.
She needs no introduction, but for the the participants from this part of the world. Dr. Neelam is a vibrant IAP president of 2026, and she has been present encouragingly all through our 2025 CMEs as well. So, Dr. Neelam, please, a few words from you, and then Dr. Singaravelu.
Yeah, thank you, Vanita and dear Singravelu and all the other seniors on this. It's always a pleasure to see how diligently on Sundays that the Bahrain team works, and we also enjoy for a Sunday 6:30 to be with you all at least once, and we are getting so much connected that hope this never stops because it feels so good to see you all, and that looks like a complete Sunday at least in a month. With those few words, I wanted to congratulate the team, and we have today Suresh and Sweta, as you highlighted from the neonatology, and on behalf of the entire IAP team, that we are blessed to be listening to this wonderful program. I enjoyed the focus that you were taking, though, to be honest, I was not able to attend completely to say that I am fully trained in it. But yes, it is always a delight to be on the forum, and I enjoyed the surgical session last time, which was very, very useful. The lady from Bahrain was really very innovative style she had of talking about the common surgical issues, and the Indian side had great wisdom in talking about it. So over to the clinical finding, and thank you so much for having us over. Over to Dr. Singaravelu.
Thank you, Dr. Dr. Singaravelu. A few words from
Thank
you.
you. Thank you, President Neela Madam, and the coordinator, Dr. Vanita Ma'am, who is doing extremely great job of connecting IAP and Bahrain together, both IAP, our Indian speaker and foreign speaker, and every month subspecialty being a neonatology, which is the need of the hour, very important, and great two speakers you have brought. I'm sure that this program will go on very well, and very happy learning. This kind of collaboration has to be continued throughout, so that one, we are knowing each other and sharing our knowledge between the countries, and the priorities can be discussed so that people can learn a lot. So which is wasting without much time. Over to you, madam. Happy learning to all. Continue your good work. Thank you, madam. Over to you.
Thank you, Presidents. Now I hand over the floor to Dr. Atta Mujib. Dr. Atta Mujib is consultant neonatologist in King Hamad American Mission Hospital. He has kindly consented to moderate today's session. Dr. Atta Mujib, can you please take over?
Thank you, Dr. Vanita, and thank you to the IAP team. So today, for the first topic, which is PDA and eternal dilemma, I'd like to invite Dr. Shweta Mohanty. She is a pediatric cardiologist with international experience. She did her MBBS and MD from KEM Hospital. Here I will stop because I did my DM in neonatology from KEM Hospital a few years back. So happy to hear that we are from the same college. And then Dr. Shweta did pediatrics board certified from Einstein Medical Center, Philadelphia. And she did a fellowship in National Board in Pediatric Cardiology from Amrita Institute of Medical Sciences, which is a very important center for pediatric cardiology in India. And currently she's working as a consultant pediatric cardiologist at Narayana Health, Bangalore. And I would like to invite Dr. Mohanty to present her topic. PDA is always a big dilemma for as a neonatologist. As soon as 24 hours finish, the baby deteriorates, whether to treat, not to treat, wait, which drug to give, what to do when surgical intervention. It's always especially for those who are extremely low birth weight babies. So I would like to hear from a cardiologist point of view. Over to you, Dr. Shweta. Thank you.
Thank you. Thank you for the kind introduction. I will just share my screen. Is my screen visible?
It's doctor.
Yes, okay, great. So thank you for this opportunity. My topic is PDA and eternal dilemma. But before I go to the dilemma part of it, I just want to run through a few basics and bring in more of the cardiology perspective into it. PDA is a very basic topic which most neonatologists encounter as one of the first few lesions that they have to treat. Let us start with the fetal circulation. So in the fetus, we know that the oxygenated blood comes via the umbilical vein, and this is directed across the foramen ovale selectively to the left heart and goes via the aorta so that the head and neck receive oxygenated blood. The deoxygenated blood from the head and neck from the SVC preferentially goes into the right ventricle, and from the right ventricle, the blood gets pumped into the pulmonary artery. Now, since the lungs are filled with fluid in utero, the pulmonary vascular resistance is high. So almost all of the blood from the right ventricle, that is 45 to 50% of cardiac output, goes via the ductus arteriosus into the descending aorta and supplies the lower half of the fetus. Now, during fetal life, the oxygen saturation of the baby is roughly 65%. This is a very low oxygen saturation, and this is primarily what keeps the ductus open along with some prostaglandins. So in utero, in fact, if the ductus closes, that in rare conditions, that can result in right heart failure, and also we see pulmonary hypertension post-delivery. But let's come to the patent ductus arteriosus. So what happens after the baby is born? With the alveoli filling with air, the pulmonary vascular resistance falls. So initially, because of a high pulmonary vascular resistance, just like in utero life, the PDA will shunt from pulmonary artery to aorta, that is right to left. Once the baby starts breathing, the PVR falls and the PDA will now shunt bidirectionally. After that, what happens is when we clamp the umbilical cord, the systemic vascular resistance rises. Now, with that, the aortic pressure will rise. So, with a rise in the aortic pressure, there will be an increased left to right shunt across the PDA. And finally, with a complete fall in the pulmonary vascular resistance, there will be a left to right shunt across the PDA. So, in the normal transition, the left to right shunt across the PDA will result in increased pulmonary blood flow, which will result in increased pulmonary venous return coming back to the left atrium. And therefore, the flap-like foramen ovale is going to get closed, and the atrial level shunt, which was initially right to left, is going to become left to right, or it is going to close off. With a rise in the newborn saturation, there is a decrease in the prostaglandin levels. So, and there is also the stimuli for ductal closure is a rise in the oxygen saturation as well as the decrease in the prostaglandin levels. So the duct will constrict and there will be functional closure of the PDA about 10 to 15 hours after birth. So within 48 to 72 hours, most of the PDAs in term newborns tend to close. And anatomical closure, that is a complete fibrous ligament-like PDA, ductus arteriosus, will be seen after about 2 to 3 weeks of life. Now, what happens in case the duct does not close? So what is the incidence of PDA? In a term baby, it is 1 in 2,000 live births. But in preterms, as we know, the incidence is much higher. So at 32 weeks of gestation, about 20% of the infants tend to have PDA. Whereas if it is a preterm baby less than 26 weeks of gestation, then almost 80 to 90% of them will have a PDA. The duct will not close. So let's look at one such example. This is a 2 days old preterm newborn who was born at 30 weeks of gestation. The baby is noted to have an increased respiratory rate of 64 beats per minute, increased work of breathing with chest retractions. The heart rate is 150. The pulses are bounding. When we look at the monitor, it shows a blood pressure of 49/16. So see how low the diastolic pressure is. It is only 16. And the MAP or the mean arterial pressure is 27. Now, a rough way to calculate the expected blood pressure for the gestational age, as we know, is the MAP is approximately equal to the gestational age. So in this case, it should have been around 30, or even roughly in all premature babies, 30 is considered a good map to have. So in this case, we can see that the mean arterial pressure is low. There may or may not be a murmur. And when we do the blood gas, we find metabolic acidosis with high lactate and a low pH. So clearly, this baby is expected to have a PDA with the diastolic pressures running so low, the pulse pressure being wide and the map being so low. Now, how does a PDA usually present clinically? So we saw that this baby had fast breathing. Similarly, the child will have a crescendo systolic murmur, bounding peripheral pulses with wide pulse pressure. The precordium may be noted to be hyperactive. There can be features of congestive heart failure and associated signs and symptoms. Which can be a little difficult to diagnose because liver is usually palpable in the newborns, but you can have significant hepatomegaly and cardiomegaly. The baby can have episodes of apnea, respiratory distress, ventilator dependence, unexplained metabolic acidosis, and poor weight gain. So what is the next step? Now we have a baby who is manifesting features of a significant patent ductus arteriosus. The first few measures are supportive measures to try and decrease the pulmonary blood flow. So we start with fluid restriction and diuretics not used initially, but may be used if there are signs of congestive heart failure. Again, here I'll add a note, furosemide can cause the duct to remain open because of prostaglandins, but this is not very commonly seen. However, thiazides or low-dose furosemide may be considered in a newborn with congestive heart failure. Now, other strategies to limit the shunt are those which increase the pulmonary vascular resistance. So how can we increase the pulmonary vascular resistance? By some ventilatory measures. So we can do permissive hypercapnia, so the PCO2 should not be too low, and minimize the FiO2 and optimize the P. The next thing that we can also do is because with the increased pulmonary blood flow, there is systemic hypoperfusion. So we would like to improve oxygen delivery to the systemic circulation. And this can be done by optimizing the hematocrit and blood transfusion wherever necessary. Now, how do we confirm whether this PDA is significant or not? This is a forum which is primarily interested in POCUS. So I would just like to talk about the common views that we look in to diagnose a significant PDA. Now the first image shows a parasternal short axis view where we have kept the probe in about the second or third intercostal space with the probe pointer directed towards the patient's left shoulder. And this is the suprasternal view where we keep it in the suprasternal notch with the probe again directed towards the patient's left. So how does the parasternal short axis view look? We will see the aortic valve in the center. Many of you will be familiar with this view. The whole of the right heart encircles the aorta. So we have the right atrium, right ventricle, pulmonary valve, and then the main pulmonary artery. So if we tilt the probe a little anteriorly towards the head of the baby, we will open up the right and left pulmonary arteries. And that is the view that we want in parasternal short axis at the base of the heart to open up the PDA. Sometimes it can be difficult to see a PDA just on 2D echo. So what we do is we add a color to it, and then we will see this shunt, which is entering the main pulmonary artery. Now, if this is the probe, any flow towards the probe is going to be red, any flow away from the probe is going to be blue. So when we have flow from the descending aorta into the pulmonary artery, we expect a left to right flow to manifest as a red color. So this is a left to right shunting PDA. How does the suprasternal view look? So we see the arch of aorta in the suprasternal view with the head and neck branches, and below that will be the pulmonary artery. Between the two, we will get a flow. And this is better seen in what is called as the ductal view or a high left parasternal short axis view. So it's a 1 or 2 intercostal spaces higher than the regular parasternal short axis view. And we almost hold the probe in a sagittal plane. And what we will see is the pulmonary artery will be bifurcating, the descending aorta will be longitudinally seen, and between them we will see the connection. And this is a good view to measure the PDA, and the PDA is usually measured at its narrowest point, which tends to be at the pulmonary end. So for example, over here, this PDA is measuring about 1.5 millimeter. Now, when do we say that a PDA is hemodynamically significant? The first thing to look at is clinically, how is the baby doing? If the there is increased pulmonary blood flow that will result in pulmonary edema, reduced lung compliance, and ineffective gas exchange. So one of the features that the preterm will manifest is not being able to come off the ventilator. There are various classification systems based on clinical features to say whether a PDA is significant or not. For example, the McNamara system is very frequently used. Another description by Sosenko is if the clinical signs of PDA associated with pulmonary hemorrhage or with cardiomegaly and signs of pulmonary edema, as well as respiratory failure are there, and or arterial hypotension requiring vasopressor treatment, then this is definitely a hemodynamically significant PDA. So how do we determine on echocardiogram whether this PDA is hemodynamically significant or not? So when there is a PDA with a left to right shunt, what will happen is there is increased pulmonary blood flow. That increased pulmonary blood flow will then come back to the left atrium via the pulmonary veins. This will result in enlargement of the left atrium and left ventricle. So when we keep the probe at the apex of the baby with the probe pointer to the baby's left, we will get this view, which is called as the four-chamber view. In the four-chamber view, now this is the left atrium, right atrium, left ventricle and right ventricle. So as you can clearly see in this view, the left atrium and left ventricle is very dilated. This is opposite of what we see in a newborn. Usually in newborns, it is the right atrium and right ventricle, which is normally larger than the left atrium and left ventricle. So finding a dilated LA and LV is the first sign that tells you on an echo that this child is having an increased pulmonary venous return, which has led to left heart enlargement. Another way to quantify that left heart enlargement is in the parasternal long axis view. Now we saw the parasternal short axis view where we keep the probe in the second intercostal space with the pointer towards the baby's left. The same position, if we move the pointer to point towards the baby's right shoulder, that view gives us the parasternal long axis view. In that view, what we do is, so we have the M mode on the echo. So we will use the M mode, put the cursor across the aortic valve leaflets, and that will result in a cut across the aorta as well as across the left atrium. And we will get an M mode trace like this, where this is the aorta, and below that we will see the left atrium. So our probe is somewhere over here. So what we do is we measure the left atrium and the aorta. Now the aorta to LA or the LA to aorta ratio will give us an approximate idea of how dilated the left atrium is, provided the aorta is not itself enlarged. So the normal LA to aorta ratio is up to 1.4. If the left atrium to aorta ratio is 1.5 or more, that tells us that the left atrium is very much bigger as compared to the aorta. Another mode of echo that we use is a mitral valve Doppler. So in this four-chamber view, what we will do is we'll put a cursor across the mitral valve and we will use pulse wave Doppler, PW Doppler. And when we use a pulse wave Doppler, we get the flow across the mitral valve. So how does blood enter the left ventricle in diastole? Initially, as we know, when the ventricles relax, there is an isovolumic relaxation period. Then the mitral valve opens and there is the first rapid filling. So all the blood that has collected in the left atrium is going to come into the left ventricle. After that, there is a slow filling period, which is called as diastasis. And finally, the atria are going to contract. So with that atrial kick during atrial systole, we get the second rapid filling. Now, how is this seen when we do a Doppler across the mitral valve? We will get an initial wave, which is called as the E wave of early diastolic filling. And then the slow diastasis is a downslope. And then we will get the second wave, the A wave, which is the atrial systole wave. So usually what happens in a newborn is ventricles are stiff. So the first rapid filling is not so much. It is the atrial kick, that is the A wave, which tends to fill up the ventricles more. So in a normal newborn, the A wave is going to be taller than the E wave. However, when you have a newborn with a significant PDA, with a lot of pulmonary venous return into the left atrium, then what happens is all that blood collects in the left atrium, and when the mitral valve opens, that blood is going to gush into the left ventricle, and that is going to result in a very tall E wave or early filling. So when you have an E wave which becomes greater than the A wave, that again tells you that this PDA is hemodynamically significant. So we talked about left heart enlargement. Then we talked about the mitral E by A wave, and we talked about actually measuring the left atrium to aorta ratio. This is a very commonly used ratio, the LA aorta ratio. What else can we do? So we can keep our probe in the suprasternal notch and take a pulse wave Doppler across the descending aorta. When we do this, blood is expected to go downwards towards the lower half of the body, so away from the probe. So it should show as a Doppler below the baseline. So when in diastole you have a flow reversal, the blood flow is towards your probe, that means in a color Doppler, you would see a blue, red, blue, red, blue, red, instead of just seeing blue flow. So when you're seeing that red flow and you put a Doppler, that gets manifest above the baseline, and having such a significant diastolic flow reversal in the aorta tells you again that this is a significant runoff from the aorta, which means the PDA is really big. So is there a classification system based on echo parameters to call a PDA small, medium, and large? Now, we all know that depending on the size of the baby, the gestational age, there is no one number that can be generalized to call a PDA small, medium, or large. We always have to put in multiple parameters to classify it, and therefore we will not go by the absolute size alone. So going by the ductal size, what is considered as small? You remember the high parasternal view where we measure the PDA near the pulmonary end. So that is a measurement we're talking about. If it is less than 1.5 millimeter, this is usually a small PDA. And more than 3 millimeter is a large PDA. So anything in between is moderate. The next thing is, before we even measure, let's look at it visually. So if we're seeing a PDA and we're seeing the left pulmonary artery next to it, if the PDA is looking larger than the left pulmonary artery, that is the PDLP ratio more than 1, obviously this is a very huge PDA. Then comes LA aorta ratio, which we discussed. If the left atrium is dilated, the ratio is going to get higher. So less than 1.4 is considered normal. 1.5 and above is a dilated left atrium. If it is more than 2.1, this is definitely an enlarged left atrium. After that, the retrograde diastolic flow in the descending aorta that we just saw, if that is present, the PDA is large. Then the mitral E by A ratio, less than 1, the PDA is small. Around 1, the PDA is medium size. But if that ratio is more than 1.5, this PDA is large. We can also measure the flow velocity across the PDA. So what we do is, we saw that red flow in the PDA coming towards the probe. You put a continuous wave or CW Doppler across the PDA and you will get a tracing like this. So you're seeing a continuous flow here above the baseline. So this is continuous left to right flow across the PDA. This is systole and this is diastole. So if you have a continuous restrictive high velocity flow, look at the velocity here, it's about 2 meters per second. Now, suppose that in diastole, that velocity is more than 2 meters per second. That means the shunt is small, because the smaller the shunt, the easier it is, the higher the speed of blood flow across it. Whereas the larger the shunt, the easier it is for blood to flow through it. So you will get lower velocities. So the velocity or the peak gradient of blood flow across a shunt is higher in a smaller shunt. So if we have a high velocity flow of more than 2 meters per second at end diastole, that PDA is small. But if we have a pulsatile non-restrictive flow where the diastolic pressure, look over here, the gradient is not much between the aorta and the pulmonary artery. What does this gradient signify? When I do a Doppler across the PDA, basically what I'm measuring is the pressure difference between the aorta and pulmonary artery. The machine measures the velocity and we calculate the pressure gradient by the formula 4V square, where V is velocity. So the higher the velocity, the higher the gradient. That means the pressure difference between aorta and pulmonary artery is huge. That means the PDA has to be small. The larger the PDA, the pressure difference between the aorta and pulmonary artery is lost. So if you can see over here in diastole, there is hardly any gradient. That means the aortic and pulmonary artery pressure is equalizing in diastole. So this is a really large PDA. So if you get a flow pattern like this, this tells you that the PDA is large. So a pulsatile unrestricted flow where the end diastolic velocity is less than 1 meter per second tells you that the PDA is large. And then what about systemic perfusion? So we can do a Doppler of the systemic veins, arteries as well, and look at the flow across them. So if there is absent diastolic flow in the superior mesenteric or the cerebral or the renal arteries, this tells you that the PDA is significant. If there is flow reversal, this is a really large PDA with a lot of steal phenomenon, where the blood is literally getting stolen from the systemic circulation and going to the lungs. What are the other echocardiographic markers? So these are the ones that we commonly use, but there are some others. We can calculate the left ventricular output by using something called as VTI, velocity time integral, where we trace the flow and multiply it by the area of the outflow tract. So we will get the volume, that is the stroke volume, when we multiply it by the heart rate to get the cardiac output. So if this value, the rough figure to remember is 200. It should not be less than 200 ml per kg per minute, because that would imply a low cardiac output. So a low cardiac output is a late feature of having a large PDA. Then comes the isovolumic relaxation time. Again, that should not increase. And we can even do a Doppler across the pulmonary vein, where we see the pulmonary vein diastolic or D wave velocity. And that velocity, the normal value is 40. So if that velocity is increased, it tells you that the pulmonary venous return is increased. Then there are other ways to see. So there is NIRS, which is near infrared spectroscopy, which is available in some institutes as a handheld device also. And there you can see the cerebral flow or the renal flow, and that can be beneficial too in a longitudinal assessment. Other biomarkers can be used. For example, you see the renal parameters, the PU and creatinine. Now, when the left ventricle enlarges in size, the myocardium releases NT-proBNP. So the NT-proBNP level will go up. This can be useful even for long-term prognostication by seeing the trend. So these will tell you that the PDA is significant. Now, what is a ductal steal phenomenon? When there is a high volume of left to right shunt, if this steals the blood away from the systemic circulation into the pulmonary vascular bed. And because of that, there will be systemic hypoperfusion. The organs to suffer are the ones which require a high cardiac output. For example, the kidneys, they require a lot of blood flow. So these are the ones where circulatory insufficiency will first be made manifest. And that is why we have features of oliguria, deranged renal function test, etc. The GI tract is another organ that can suffer. So the diastolic runoff is going to affect pre-ductal organs, like for example, the coronary arteries and the brain as well, and that will cause a coronary steal. Now we know that the heart is perfused by the coronary arteries in diastole. So when the diastolic pressure falls, the myocardium gets prone to more ischemia, and this is a heart which is already having to deal with extra volume because of the PDA, plus it is not being perfused well. So there can be myocardial dysfunction, which can lead to congestive heart failure. So what are the complications associated with PDA? The lungs will suffer because of increased pulmonary blood flow. There can be respiratory distress syndrome and pulmonary hemorrhage with a requirement of ventilation for a long time and the associated problems of increased ventilatory duration like infection and bronchopulmonary dysplasia. Then in the brain, there can be intraventricular hemorrhage, renal dysfunction, because we said the kidneys suffer early, necrotizing enterocolitis when the GI has hypoperfusion, then periventricular leukomalacia, which is seen in preterms, and increased mortality. So all of these complications may be seen with a PDA. So how do we manage the PDA? Now in utero, like we know that the saturation is low, there are prostaglandins, the arachidonic acid is acted upon by COX enzymes and prostaglandins are released. These act on EP4 receptors and keep the duct patent. So what we will do in the postnatal period to close the PDA is act on the COX inhibited and try to close the duct. So initially, the drug that was used more was indomethacin, and the dose would vary based on the gestational age and the weight and the days of life as well. So the usual dosage would be around 0.1 to 0.25 mg per kg per dose IV every 12 hours. Then there came a phase where the shift was seen towards using ibuprofen, and ibuprofen, again varying doses, but usually loading dose of 10 mg per kg on day 1, followed by 5 mg per kg per dose on after 24 and 48 hours. So why was there a shift towards ibuprofen? Because of the problems of renal dysfunction, platelet dysfunction, etc. seen with indomethacin. So with ibuprofen, it was noted that there is less oliguria, less incidence of necrotizing enterocolitis, and it is equally efficient as compared to indomethacin. Plus, it is also available in oral form. And now we have a shift which is towards acetaminophen or paracetamol. So paracetamol is used in a dose of about 15 milligram per kg per dose every 6 hours for about 3 days, and it can be given both IV as well as orally. Now, what about transcatheter PDA closure? Because this is a newer modality which is being used to treat the PDA, and it is increasingly being performed in extremely low birth weight infants. Now, the device which has been approved for transcatheter PDA closure in preterm infants is the Piccolo device. And the FDA cutoff to be able to use this device is a weight of about 700 grams. So if we have a newborn of 700 grams and above, we can consider transcatheter PDA device closure in those who do not respond to medical therapy. What are the complications of using a PDA device? Uncommonly, it can cause coarctation of aorta. So we have the PDA between the aorta and pulmonary artery, and we're placing a device. The device is going to have discs which are going to sit, one at the aortic end and the second at the pulmonary end. So if this aortic end is going to protrude into the aorta, it will cause obstruction, but this is less common. The other one, that is the pulmonary end of the device protruding into the left pulmonary artery, is more common. So it can cause LPA stenosis. And if the procedure used an arterial access, like let's say the femoral artery, so there can be vascular complications related to the arterial access site as well. Uncommon complications of doing a transcatheter PDA closure are device embolization, or very rarely, because it is a preterm infant where we're using these wires and catheters, there can be cardiac perforation, but this complication is rare. So the one that I mentioned, that is left pulmonary artery obstruction, what has been found in studies on long-term follow-up is it usually tends to improve with time. So transcatheter PDA closure by a device is definitely a good option. Not every center uses Piccolo. There are microvascular plugs, etc., that have also been used, but the device that is FDA approved is the Piccolo device. Then we come to PDA surgical closure. So this is the traditional way. When we're having failure of medical therapy, then we think of PDA surgical closure. So what are the advantages of a transcatheter closure over PDA surgical closure? You're avoiding an incision, so you have a decreased chance of infection. But yes, we dealt with the complications of having a device sitting over there. What is the advantage of surgery? It is a good option when medical treatment is contraindicated. Let's say this baby is too sick to be able to tolerate the COX inhibitors. And the advantage of PDA surgical closure is it can even be done bedside. It helps with early extubation and lower hospital stay. However, studies report that when you do a PDA surgical closure, that does not reduce the morbidity associated with the PDA. For example, bronchopulmonary dysplasia, ROP, and neurodevelopmental outcomes can still be poor in those babies who have undergone an early PDA surgical closure. The other problem is when you're accessing the duct via a surgical incision, you may inadvertently damage the phrenic nerve, or there can be vocal cord paresis, and of course wound infection. Now, there is one complication that happens after surgical closure of the PDA, which is the PLCS, or post-ligation cardiac syndrome. So what happens over here? Generally, in normal physiology, the PDA will close slowly and the heart gets used to pumping against the increased aortic pressure. Now, what is happening over here is you have the blood coming out of the left ventricle into the aorta, and there is a duct which is allowing an easy outflow of blood. So there is a low resistance circuit in the lungs where the blood can easily flow. If you suddenly close the PDA by a PDA surgical closure, the left ventricle now is forced to pump against the high aortic pressure or high SVR, and the LV may not tolerate it, and this is what the post-ligation cardiac syndrome is, where a sudden increase in afterload and a decrease in LV preload can result in decreased cardiac output, hypotension, metabolic acidosis, and respiratory failure. Now, let's continue with the same case. So we started with this baby, premature baby, who had a low diastolic pressure and a significant PDA, and we started medical treatment for the baby. This baby is ventilator dependent. The blood pressure now is 36/16. So the diastolic was always low, it was 16. But now even the systolic pressure has gone down. So what does this tell you? This is telling you that this is an even advanced stage of congestive heart failure because of a patent duct. The implication is that the LV is unable to compensate for this increased preload because of all this pulmonary venous return coming back to the heart with a low coronary perfusion and immature preterm myocardium. So at this point, what do? There can be signs of hemodynamic instability, that is low systolic and diastolic BP, signs of low cardiac output, so poor peripheral perfusion, prolonged capillary refill time, poor peripheral pulses, elevated lactate, metabolic acidosis, low urine volume. So at this point, the heart itself needs to be supported. So in an advanced phase with compromised cardiac output, we need to give inotropes. Now, what inotrope will we give? We need to give an inotrope that is not going to increase the systemic vascular resistance, because you have a failing myocardium, and if we're just going to target, let's increase the systolic BP by giving an inotrope which is going to be alpha adrenergic, what is going to happen is you're going to make a failing heart beat against an increased afterload, and that is going to worsen the cardiac function. So here the target should not be to try and increase the systemic BP. The target should be to try and support the cardiac contractility. So in this case, the inotrope of choice would be dobutamine. It can raise the cardiac output by increasing the stroke volume by its beta-1 action. So it preserves systemic vascular resistance because it has this mild beta-2 action, which will cause peripheral vasodilation, and mild alpha-1 action, which causes constriction. So the two balance each other out. So there is not much change in the blood pressure. So what you're doing essentially is you're helping the myocardium. So dobutamine is a good option. Avoid inotropes which are simply going to increase the systemic vascular resistance. So avoid dopamine because it increases pulmonary as well as systemic vascular resistance. Avoid giving vasopressin and norepinephrine because these increase SVR. They don't change PVR much, but yes, they increase SVR, so they increase the afterload. And if we're going to give an inotrope which is going to cause a lot of peripheral vasoconstriction, that again in turn is going to worsen end-organ perfusion. For example, the kidneys, which are already not getting enough flow because of that steel into the lungs, now we're going to vasoconstrict the renal artery, and there will be even worse perfusion of the kidney. So in these cases, avoid drugs that only cause the SVR to increase. Dobutamine is a good choice. What about prophylactic closure of PDA? And this is the dilemma because there was a trend in the middle to prophylactically close the PDA with medical management in extremely low birth weight babies. The reason is it can decrease the morbidity and mortality, and there can be a reduced incidence of intraventricular hemorrhage. However, it is found that if we prophylactically give medications to close the PDA in preterms, there is no decrease in the BPD, NEC, ROP incidence or long-term neurodevelopmental outcomes. And so studies have found that there is not really much benefit in prophylactically closing it before it becomes hemodynamically significant. In preterms between 26 to 28 weeks, there can be an increased incidence of late onset sepsis. So especially when drugs like IV, indomethacin, etc. were used, the sepsis rates would be higher and death was observed. So therefore, there is a dilemma whether to do a prophylactic treatment. The other problem with prophylactically treating it is that you have closed the PDA, and after a few days, the PDA can reopen. I'm sure that many of us would have had that experience. And then you're again giving a second course of medical therapy to close the PDA. Plus, there are adverse effects of the drug for an extremely preterm baby, like intestinal perfusion, acute kidney injury, which you want to avoid. So the trend now is not to go for prophylactic closure, but to actually see for HSPDA and then only close it. Now, I think I'm nearing my time of like the end of the talk, but there are two cases that I want to quickly run through. PDA in a different scenario. So let's talk about another baby now. This is a term baby who has a history of meconium aspiration and is having cyanosis and fast breathing in the first few hours of life. So what are we thinking of? The lung parenchymal involvement in a meconium aspiration syndrome. And when we see the saturation upper limb and lower limb, upper limb sats are 85%, lower limb sats are lower. So obviously the PDA is shunting here right to left. And with minimal changes in the ventilatory settings, the saturation is changing, which again tells you this is a labile PA pressure. So what is happening in this case, because of the lung parenchymal issue, there is a decreased fall in the postnatal pulmonary vascular resistance. So the RV is going to have to pump against high pulmonary artery pressure. This will cause impaired RV performance. And because of the RV pressures rising, the patent foramen ovale is also going to shunt right to left. And because the pulmonary vascular resistance stays high, the PDA is also going to shunt right to left. So the saturation will be low. Now, is this a child where you will give medical therapy to close the PDA? No, because over here, what is happening is the PDA is acting as a pop-off. So it's like a pop off for the right ventricle. Otherwise, the right ventricle will have to pump against this high PVR and will fail all the more. So when you see a completely right to left shunt across the PDA, that will manifest as, that is pulmonary hypertension in the newborn, will manifest as labile oxygenation, differential saturation, profound hypoxemia despite oxygenation and mechanical ventilation. In these cases, PDA supports the circulation during the maladaptive transition by acting as a pop-off for the right ventricle. So this allows blood to egress from RV to the systemic circulation, because RV is not a pumping ventricle. LV can pump better. RV cannot pump against high pressures. It has limited contractile reserve. So with an increase in afterload, it will tend to fail. So if we see a PDA with a completely right to left shunt, don't go and close it, because if the PDA is closed in this setting, it can precipitate RV failure. And how will it look? If the pulmonary and aortic pressures are almost equal, you will, when you put a Doppler across the PDA, you will get both left to right as well as a right to left shunt or a bidirectional shunt. But if the pulmonary artery pressure is really much higher than the aorta, then even in diastole, the flow will be right to left, and you will only get flow below the baseline. That is, it can be a completely right to left shunt. How will we manage it? So measures to decrease the pulmonary artery pressure. For example, inhale nitric oxide, or we can give milrinone, because milrinone is an inotrope that will help with RV contractility as well as decrease pulmonary vascular resistance. And if there is low systemic BP, we can also consider inotropes, and we can actually try to keep the PDA open by giving prostaglandins. So instead of trying to close the PDA is actually helpful in these situations. And then we can give pulmonary vasodilator therapy. I will not go into the details of this because this will fall under the purview of another talk. But this, some considerations are, one, we should not make an effort to increase the post-ductal saturation by providing a high FiO2, because you're only going to try and increase the pulmonary blood flow. This is not going to help with the PVR. And secondly, if an effort is made to try, because if you have a high PVR and you feel that if I increase the aortic pressure, I'm going to start getting a left to right shunt, so my saturation will improve. So trying to increase the aortic pressure simply by giving inotropes which are going to increase the SVR, this is a completely wrong strategy, because just increasing the left to right shunt by increasing the aortic pressure is not going to benefit the lungs. You're not going to improve the lung parenchymal issue, which is the main problem. So that again is a wrong approach. Now let's come to a third case, term newborn brought with lethargy, fast breathing, respiratory distress. So can paracetamol be given for more than 3 days, like 5 to 7 days? Is it useful? So we will come to the questions during the discussion, I think, but the usual duration is about 72 hours. I would like the neonatologist to comment on their individual experiences. Usually we do repeat a course after a gap if we do not see an improvement, but the general usage time is about 3 days. So coming to the third case, day 4 of life, brought with lethargy, respiratory distress, saturation. Upper limb is normal, lower limb is abnormal. But what is the difference in this case compared to the previous one? The previous one also had differential saturation. The difference here is, look at the blood
This is the
pressure.
last case,
Upper limb,
Doctor?
I'm sorry?
This is the last case because time.
Yes, so for want of time, I'm just going to wrap up in another minute. So this is a cardiac case with differential saturation. So this was a coarctation of aorta. So talking about duct-dependent congenital heart lesions, these can be those congenital heart defects where the PDA determines the cardiac output of the left ventricle, for example, severe coarctation or HLHS. Then there can be duct-dependent pulmonary circulation, for example, pulmonary stenosis or pulmonary atresia. So in all of these cases, the PDA actually plays a role in maintaining circulation until treatment can be done. So in these cases, it is very important not to blindly give oxygen, because if we close the PDA in a duct-dependent circulation, that can be life-threatening. So it is very important to rule out a congenital heart disease and a duct-dependent circulation before trying to close the PDA. The only congenital heart lesions where we will not want a PDA are those where, let's say, the pulmonary venous return is obstructed, like say a TAPVC. Then we don't want the PDA to be open. Or those where the pulmonary blood flow is already increased, like for example, truncus. So in these cases, we don't want the PDA to be open. So to conclude, a PDA can be physiologic. We don't have to rush and treat every PDA unless it is hemodynamically significant. So if the PDA is not contributing to cardiovascular instability, it is best to leave it. If it is pathologic, directly causing cardiovascular instability, and we saw all the echocardiographic parameters which determine whether a PDA is significant or not, then the treatment options start with fluid restriction, shunt limitation strategies, optimizing oxygen delivery, and the medications, as we know, are those which inhibit prostaglandin synthesis, the other options being transcatheter or surgical closure. And finally, a PDA can be supportive in two conditions: pulmonary hypertension and duct-dependent congenital heart lesions. In these cases, it is vital to ensure patency of the duct. So that brings me to the end of my talk. Thank you.
Thank you, Dr. Shweta. Very accurate and specific presentation. The role of PDA in every possible way, in a preterm, in pulmonary hypertension, ductus dependent. So all those who are practicing newborn care should be aware when to close PDA, when not to close. That is also more important than to close. So questions and answers we'll take at the end of the other session. So we'll go ahead with the second speaker. I would like to invite Dr. Yahya. He is a highly experienced consultant neonatologist, educator, researcher, innovator with over 24 years of experience in clinical practice across Canada, Australia, and Middle East. Currently, he is working as a consultant neonatologist and coordinator at the Neonatal Emergency Transport Services and Maternal Child Hospital in Tabuk, Kingdom of Saudi Arabia. His key expertise is neonatal intensive care, point of care ultrasound, neonatal transport services, and medical innovation, AI, and smart monitoring. I'll over to Dr. Yahya for your session. His topic will be to do or not to do. Always, as a neonatologist, decision, or anyone who is practicing newborn care, whether to intervene, whether to wakeful watch, always a dilemma, even for the small things. Hope after this session will be more clear how to go ahead. Over to you, Dr. Yahya. Thank you.
Thank you, sir, very much for a very comprehensive introduction. I wish and I hope, I feel inflated. I wish that I deserve this a nice comprehensive intro. Now when you read in books, you feel that things are easy. 1 + 2, 1 + 1 = 2. That's the problem in neonatology. It's not that. And I say always, neonatology is science of machine. There is no diagnostic dilemma because we have a couple of diagnoses. The problem is in the management. So I'm going to give you scenarios, and I want to see whether we should do or not. And then I will tell you what I do. However, not all what I do is evidence-based. As you know, most of our practice, we wish there is evidence, but most of the time we depend on physiological evidence rather than evidence itself. So the objectives of this talk is to talk whether to start antibiotics or not, whether to stop antibiotics or not, whether to cool or not, whether to resuscitate or not, whether to intubate or not, whether to extubate or not, whether to admit or not, and whether to discharge or wait. So to start antibiotics or not, so here we have a 37 plus 3 weeks newborn baby born by C-section for maternal reason. There is no prom, and the GPS is negative. The mother is not in labor, so just concentrate on these. The maternal white BC count is 13,000. Temperature is 36.5 degrees Celsius of the mother. HIV, hepatitis B, are all negative. Rubella immune and VDRL negative. The baby born in an acceptable condition. The Apgar score was okay. But at 30 minutes, the baby started to have tachypnea and retraction. Chest X-ray, nothing very impressive, only wet lung. You can also say in lung ultrasound, you have more B lines than A lines. And the CPG showed that the pH is 7.3, PCO2 is 31, bicarb is 19, lactate 3.5. The baby on CPAP, 6 centimeter water, FiO2 27%. So what we do? CBC, blood culture, ampicillin and gentamicin. CBC, blood culture, ampicillin and gentamicin, CRP, ESR, or procalcitonin. CBC and blood culture, no antibiotics. CBC, blood culture, inflammatory markers, no antibiotics. Wait, or you have other plan. So, and the other question is to start antibiotics or not. So here we have 27 weeks, born to a mother with pregnancy-induced hypertension. She is GDM, needed intubation, giving surfactant, extubated, sepsis workup was done, and started on ampicillin and gentamicin, seen very common. Currently, 48 hours. Blood culture is negative, and you have 3 scenarios. The white BC 8,000, the white BC is 4,000, the white BC is 3,000. In neutrophil also, they have 3 scenarios, 2,500, 2,000, or 1,900. The IT is 0.2 in all cases, hemoglobin 13, and platelet, you have 120, 50, and 60. The ABG is stable, lactate is okay, the baby is on 8 centimeter water, FiO2 21%. Echo showed, somewhere 2 millimeter size PDA with an team discretion to treat. Chest X-ray is wet, and CRP is 42. So what to do? To stop antibiotics, continue same antibiotics and do another culture, or change to another antibiotics and do blood culture. So here, what I do, what my practice. Now, it can be with evidence, it can be without evidence. So usually there is risk factors plus signs and symptoms. If both, I do sepsis workup, I start antibiotics. So what are the risk factors for neonatal sepsis? The mother in pain, because remember, labor pain can be by infection. Or you have a prom, more than 18 hours, and 4 hours for herpes. Mother is febrile. There is leukocytosis in the mother. There is uterine tenderness. GPS is positive, not treated. You have positive culture in the mother fluid. There is history of previous neonatal sepsis, or there is history of neonatal death. There is fetal distress, or there is fetal growth restriction. All these are risk factors for infection. And you have symptoms, and these, a baby is not responding to second step of resuscitation in an RP. Prematurity can be by infection, so less than 37 plus 0. Respiratory distress, poor activity, hypotonia, distension, vomiting, hypoglycemia, temperature instability, tachypnea, bradypnea, apnea, seizure, feeding intolerance are all signs of infection. So if both, I do sepsis workup. And it's not septic workup, it's a sepsis workup. So we do CBC, culture, we do ampicillin and gentamicin. We give 36 to 48 hours, depend on the institute. And I usually stop at 48, whether there is a report of no culture or there is no report, mean there is no positive. And the baby is asymptomatic. I stop antibiotics at 48 hours. But if we have a risk or symptom, So neither risk. So if we have symptom but no risk, or we have risk but no symptoms, what I do is I monitor, and especially if I have a cause of the symptom, I monitor the baby, I do CBC, I do vital signs every few hours, and I leave the baby in the hospital for 48 hours before I discharge. So here is my kind of flow chart, what I do. I do sepsis workup. If culture is positive, I keep repeating the blood culture every 48 hours until I have 2 culture negative 2 days apart. And I give the antibiotics depending what I'm growing between 7 to 14 days. Now, if you are old enough and you're like, let's say before 2000, we do it longer than this, 14 to 20 days. And then we say, no, it's 14 days. And now people going to 7 days. And now even people go to 5 days. However, if you have meningitis or gram-negative, you need to give longer antibiotics with 2 culture. And so I finish the course, 2 culture negative, 2 days apart, I stop the antibiotics and the baby asymptomatic. Then I send baby home. If the culture is negative, but I have a clinical suspicion, I give antibiotics 5 days. I repeat blood culture every 48 hours. If 48 hours culture and negative and asymptomatic, I send baby home. When I monitor the baby when there is risk or symptom, not both of them, then I do CBC, I monitor as I keep the baby. No sign and symptom, I send baby home. Sign and symptom, I do sepsis work. If symptomatic, I go for 5 days antibiotics, same. So now, whether to cool or not to cool, so this is a scenario, and I try to make the scenario as neutral as possible, as gray as possible. So you have 37 weeks, plus 0, born to a mother with pregnancy-induced hypertension, and she is GDM. The baby hypotonic, need positive pressure ventilation for 3 minutes. Apgar score at 1, 4 at 6 was 5, 1, 5, and 10. Currently at age of 3 hours. Cord pH is 7.01. Base excess is -14. Have mild respiratory distress, but responded to nasal cannula 2 liter per minute flow. FI2 about 25%. Clinical assessment showed mild lethargy. No, by lethargy, I mean the baby is not actively moving. So mild hypotonic, poor, but can suck, no respiratory distress, respiratory rate about 45. So what to do? Start cooling? Not to start cooling. Wait and assess again in 4 hours. So this is a simple table for severity of the neonatal encephalopathy due to hypoxic ischemic encephalopathy, which can include category of level of consciousness, the activity, the posture, the tone, the reflexes, and so on, and then kind of grading for each of it. And this can be repeated at birth, at 1 hour, 3 hours, and 5 hours. So here, how I do cooling on current practice based on the best evidence. Although now the trend because of the simplicity of cooling, because of availability of cooling, however, the cooling is not without side effects, especially the comfort of the baby. So if the baby is gestational age more or equal than 36 weeks, and so this is not hours, this is days, sorry. And any of the following, there is metabolic or mixed acidosis, where the pH 7 at birth or later, less than 7, or base deficit more than 16, or the bicarb less than 12. We need 10 minutes, Apgar score less than 5. And there is ongoing resuscitation. It has to be cumulative for more than 10 minutes, whether it's invasive or non-invasive support. And then you have one of the signs of encephalopathy, at least 3, on clinical examination. And this is the chart or the graph that I use to decide to cool or not if the baby meets one of these criteria. So first, there should be, baby is more than 36 weeks, and there should be a sentinel event. And any of two. The Apgar score at 5 minutes less than 10, or you have blood gas finding, and clinical seizure, or 3 of below 6 categories on any hour I start cooling. Now the question is to resuscitate or not to resuscitate. So here we have 41 years old primate with a baby born at 22 plus 5 weeks, and the baby is male, which was a productive of IVF pregnancy after 21 years of infertility. The antenatal ultrasound showed no obvious malformation. Umbilical, uterine, and middle cerebral artery Dopplers are positive. The amniotic fluid index is 8.5 centimeter. The expected weight 480 grams. Now what to do? To resuscitate? Resuscitate and transfer to an ICU to decide with parent? Or resuscitate with full care regardless? Or do not resuscitate, just give comfort care? Now, there are lots of study about the peri-viable borderline gestational age. And these studies giving you the outcome from Canada, from the US, from Europe, and even from Middle East. And it gives you variable percentages of survival, of morbidity, and mortality. Lots of studies. So at the end, I will give you what I will do. And because there is to resuscitate or not to resuscitate is almost going with to intubate or not to intubate. So I'm going to discuss to intubate or not to intubate before I give you my opinion. So we have 29 weeks male baby delivered to a mother at the age of 32 weeks. She is having one previous baby by vaginal delivery. And she received 2 doses of antenatal steroid 72 hours and 48 hours ago. No active resuscitation was needed when the baby born. At the age of 3 minutes, connected to CPAP for some respiratory difficulty. At the age of 1 hour, the FiO2 was 29%. On CPAP of 7 centimeter water. X-ray show mild haziness. And I'm using X-ray, not ultrasound, because that's more common. I hope that ultrasound will be standard of practice and we have 0 X-ray at the unit, but I don't think this is the case. So I'm using the X-ray as the standard imaging kit. The CBG show the pH 7.22, CO2 49, bicarb 17, and basic sus -6. So with the question to intubate and give surfactant, then ventilate, to intubate and give surfactant, then extubate using Ensure, to do LISA or to do SALSA, or just wait, repeat blood gas, repeat X-ray, and if reconsider your decision in the future. Now here what I do. If I have acute respiratory distress, I give CPAP. If the FiO2 less than 40% and the respiratory effort are sustained, then I continue with CPAP. I obtain ABG, CBG if you cannot. And if the FiO2 more than 40 and pH less than 7.2, then I give surfactant. If the baby got apnea or from the beginning and FiO2 more than 40%, then in both scenarios, with blood gas or without blood gas, I intubate and give surfactant. Then I obtain a blood gas. If the FiO2 less than 30% and the pH went up to 7.25, I extubate. If FiO2 remain more than 30%, I reconsider another dose. If the FiO2 after on CPAP less than 40% and the gas from the beginning more than 7.2, then I continue CPAP. And I depend mainly on American Academy of Pediatric evidence. Now, I do have something called surfactant tools where I decide to use it. This is mine. This is not standard. I depend on the gestation, whether more or lower than 7.2, whether it's a prophylaxis, whether it's acute rescue or late rescue, then I decide, depend on this surfactant tool. So if the baby more than 72 weeks and less than 34 weeks and at 30 and the baby is more than 30 minutes, I never give before 30 minutes because I think there are many important issues in golden hours, such as I'm going to give you a little bit temperature control, humidity control, sugar control, are way more than important than respiratory support. And believe me or not, most of these complications not from respiratory support. So I never give surfactant before 30 minutes. I never give it as a prophylaxis. I give it as early rescue. So if more than 30 minutes and the CPAP more than 70 meter and for more than 15 minutes and FiO2 is still high and the age is less than 30 weeks and mom has not received surfactant and the baby is more than FiO2 30% for 15 minutes, to keep saturation more than 93, I give surfactant. If the infant have more work breathing, I give surfactant. Or if in the CO2 is more than 60, I give surfactant. So I usually give surfactant if I check 3 boxes. Now, to resuscitate or not to resuscitate, so here is the scenario again, because I gave you the intubation. Now, the question is offer full resuscitation and transfer to an ICU for full care, offer active for resuscitation, then transfer to an ICU, then to decide DNR or not, or offer for resuscitation, then meet in an ICU to decide to continue or not, or consider it is a portion, give comfort care, not active resuscitation. Now, here I will decide institutional policies, resources, ethical framework, consensus from multidisciplinary team on the answer to key clinical questions regarding the management of very viable infant. Factor that affects the survival is gestational age, birth weight, gender, being a male is a risk, plurality, whether steroids are received, initial active intervention, temperature at birth, sugar at birth. All these affect my decision. So for neonate less than 22 weeks, resuscitation is as a standard not over or provided, but this is not obsolete. It can be sometime resuscitated, depend on the scenario. If 22 to 22 plus 6 and the weight is less than 500, resuscitation is optional, and I usually involve parent to decide. And sometimes I use calculators using the gestational age, the birth weight, the gender, the plurality, and antenatal steroid. If more than 22 plus 6 and more than 500, and in most states, and depend on state regulation, usually we give full resuscitation. Now the question is to extubate or not. So here we have 26 weeks, day 6, TFI is 150, UAC, UVC, TBN, feeding, EBM, 4 ml every 2 hours, off antibiotics, ventilated, PC, or it's SIPBV or PTV, whatever the name used, AC, plus VG 3.5 ml per kg, PEEP is 5 centimeter, FiO2 26%, rate, IT reasonable, slope is 30% of the IT, ABG is okay, birth weight is 80-70, today weight 80-40, gained about 6 grams in last 24 hours, past stool, last x-ray done 2 days ago show well inflated lung. So here is the scenario, baby is orally ventilated, stable. Do you extubate and give CPAP with a risk to deteriorate and maybe re-need intubation? Give PSV trial if successful, extubate, keep and be peace of mind for a few more days and then reconsider. Switch to PSV plus VG and keep for a few more days and then reconsider. So here how I decide on, and maybe I'm wrong, maybe I'm somebody practicing in a different way. That does not mean they are wrong. The decision to extubate is very challenging, especially if now the parents are very aware and they can complain, and especially if somebody complain, and then you go to an investigation committee, why you explain, especially. No, when there is no complication, nobody will question, but if there is a complication, you start to be questioned, what is the standard, why you extubate, and you'll face other people experience and people mixing up between difference of approach or different of care and medical error. And also some people are confused between error and medical error. So I consider all these when I decide. So if I decide to extubate too early, baby may have poor cardiac exchange, a clinical instability. I might give additional harm, including potential reintubation. And believe me, whatever you do, the reintubation risk is high. If I go too late, may cause lung injury, increased possibility of PPD, spelling error, sorry, or CO2, and may lead to poor cerebral flow. So these are considered when you're too early and too late. In my practice, I discontinue if two of following are met. There is no concrete contraindication to extubate. There is no severe neurological impairment. There is no airway malformation. And there is no extra ongoing care of artificial airway. There is adequate gas exchange in maintained with low minute ventilation. Typically, I need 10 to 20 with the mean airway pressure less than 10. I usually extubate. And thank you very much. I have more scenarios, but I decided to stop here because I would love to chit chat and get more questions. Thank you very much.
Thank you, Dr. Yahya. These questions are was a day-to-day practice and confusion for a newborn, especially for the medical legal issue, especially for those who are born borderline 22, 23 weeks, whether to resuscitate or not. Cooling is another important decision when you find a baby in encephalopathy, the blood gas is not matching, what to do. So very nice coverage for all those topics. And I'll ask audience for any questions they have for both of the speakers. Most welcome for the question and answer session.
I think, Doctor, we'll take questions after the next segment also.
Oh, okay. So Dr. Vanita will be presenting a short case and focus and beyond the scan. Then we'll take the question and answer. Okay, Dr. Vanita.
Thank you. Thank you. After two engaging sessions of power-packed knowledge-based sessions, I'll follow through. I'll walk you through a simple case which evolved as it evolved under our care. And I would like to invite all the experts in the panel as well as in the audience to walk through the case as well while I do. The idea is to focus on the POCUS. This is called the POCUS Plus segment. And why it's important here is it's a case of shock, and POCUS is one of the tools which is standard of care in assessing shock, as well as in integrating decision-making with shock management. So that's how this case happened to be here, yet how POCUS may not be and all but all unless physiologic integration is appropriate. So how the nuances and subtleties which can add up to POCUS is what POCUS Plus is. So let me quickly walk through this case. We have a POCUS expert and a cardiologist, so this makes it more interesting. That's how I said in the beginning, this POCUS Plus segment could be a little more interesting than the usual POCUS Plus segments. So let me get started. This is a case of a 5-week-old term-born infant present with 2 days of probable diarrhea and poor feeding. The mother reported increased stool frequency. That's how diarrhea. There's no blood or mucus. There's no vomiting. Probable fever. Mild fever is what Parents reported, although no recorded temperature suggesting fever. Notably, since birth, the infant had persistent fast breathing, which was not perceived to be abnormal by parents. Parents thought that's something normal, as the feeding and weight gain was good enough. Over the past 48 hours, the infant became less active, worse, increased work of breathing. This prompted the parents to bring the child to the clinic. Initial assessment, child was having tachypnea. There was subcostal retractions. Oxygen saturation even at room air was appropriate, 100. Peripheral pulses were weak. Delayed capillary refill, mild hepatomegaly, no significant murmur. NIBP here, it recorded 108/86. Usually, we have this dictum in ER or ICUs whenever the pulses are not palpable, pulse are weak. We don't pay much importance to measurement, NIBP measurement, because it's oscillatory method. It's bound to be erratic. I've noted the measure which we got, and at the time of measuring, we said we'll keep a reevaluation as our probable intervention, and will not give much importance to this PP. The working impression here was dehydration with possible early sepsis, given the diarrheal history, although we were skeptical about taking the diarrheal history. So what we did next. So this is where the focus came in. The initial intervention was 10 ml per kg normal saline bolus, not rapid bolus over half an hour, while this was already a shock by definition. There was poor perfusion, poor pulses, BP, we will not give much importance to it. And here we have a respiratory distress as well. This bolus of saline was given and a parallel focus assessment was done. It could be considered as a post-bolus assessment. What we had here, hypodynamic cardiac function, no pericardial effusion, good volume cardiac chambers, IVC good volume, but respirophasing. Right ventricle appearing more prominent than the left. We heard from the speaker, the right-sided heart being bigger is a norm in neonatology, like newborns. Then what we saw, the beauty of focus is we have additional insight into the other areas which will give a comprehensive picture. So we had a lung ultrasound information. It showed occasional B lines, more A lines, no effusion, can be construed as normal lung. Reassessment of the physiology. This is a focus assessment, hypodynamic heart, respiratory distress and physiology, but a dry lung. Then we assess the physiology. The pulse seemingly resolving, perfusion seemingly resolving. It appeared to improve. We putting 2 and 2 together, it seemed like, what would one think at this juncture? The presentation was respiratory distress, poor perfusion, shock, plausible history of diarrhea. And then we intervened with Ebolas, and when we are doing a focus, this is what we see. Heart is good, heart is recovering, but there's no volume deficit. There is good volume, not dehydrated, but still hypodynamic. And the cardiac function is good. The lungs are dry, so there's no congestion. So at this point, the decision was probably the manifestation of dehydration or because of, say, diarrhea or sepsis is resolving. The hemodynamic aspect is resolving with the first intervention. So this is what we thought. Then I'll just give you a sneak peek as to what the focus assessment was with the clip, and then I will invite the opinion of the experts here thereafter. So let's see the focus. The initial part would be the IVC. You can see it's good enough volume, it's not a dehydration, it's in shock. The volumes are full. You can see the left, the left.
Dr. Vanita, your voice is breaking. Your voice is breaking.
It does. So I'll just summarize the clip after the clip. Sorry, during the clip, the voice breaks, so I will review it. I'll play the IVC good volume, the chambers good volume, occasional B lines, the lung predominantly A lines, and the bladder is already showing some urine. So I'll just play the clip again and I'll go back to the discussion. IVC. chambers proportional, right more than left. The bases, A lines. So overall, it was a good heart, full chambers, IVC full enough, not a dehydrated picture at all for a shock. And the perfusion correlating with the physiology, perfusion improved after the fluid bolus. So given what happened further, the tachypnea persisted. The manifestation was tachypnea with clear lungs, so no lung pathology. Suspected compensated acidosis, common manifestations, the Sudan present. So the working diagnosis shifted towards possibly sepsis with the acidosis, compensatory respiratory manifestation, or IEM with possible inborn error of metabolism with the acidosis. So it kind of tilted towards that. So we have a running checklist whenever we have a critical infant. We ran through it along with the initial investigations which we gathered. Infant was admitted, started on IV ampicillin and gentamicin with the probable working diagnosis. We started on HFNO. There, to run through this checklist, we couldn't zero in on much. The sodium, potassium, glucose suggested to rule out endocrine possibilities, metabolic, there was no dyselectrolytemias, there was no inborn error of metabolism because there was newborn screening done, which ruled out that possibility. And we kind of zeroed in on probably heart, probably sepsis. There were evolving clues over time. There was evolving murmur, which became more appreciable after the initial interventions. And the CBC, CRP, procalcitonin, they all were unremarkable. Viral rapid antigen tests were negative. And as I said, apart from the blood gas, which had normal and gap metabolic acidosis, there wasn't much information we could gather apart from an evolving murmur. So here we stand. Why tachypnea despite clear lungs? Why persistent tachypnea? Why full chambers and IVC? This goes against the possibility of contracted heart, like a loss of preload being the reason. And why poor perfusion? Poor perfusion when there is a good heart, good preload, still poor perfusion. This could mean there is a loss of afterload, but that was not the picture. The BP we got, there is no warm peripheries, which would suggest a distributive shock phenomenon. So why murmur appeared after an initial stabilization? So the reveal here was the 2D echo. We happened to do the 2D echo because we were in a quagmire, and what we could do was 2D echo. This revealed Schwann's syndrome. Schwann's syndrome is a complex of lesions in the left side, coarctation of aorta, supravalvular mitral link, parachute mitral valve, subaortic stenosis. Our situation, there was coarctation of the aorta, there was a large ASD, there was parachute mitral valve, mitral stenosis, and that happened to be the case, which presented, conserved for 5 weeks and presented. This is not very unusual, but this was our unusual encounter. So the repair was done promptly the next day and in a cardiac center. The reason why it figures here is the subtleties of focus, where we could have possibly picked the nuances. The missed clinical sign here was we didn't integrate this upper and lower perfusion in congruence. So this revealed the major, this retrospectively, there was a definitive differential in the BP and perfusion, but not in the saturation. So this was the missing clinical physiological integration, which we couldn't gather until we possibly did the 2D echo. So why murmur? It reached a sonic threshold only after some hemodynamical interventions, like say the bolus, possibly that, and also oxygen that we heard the previous speaker, and until which time we didn't have it. if you notice, initial poor perfusion was assessed in the lower limb. And after intervention, what we were assessing was the upper limb, which probably gave us an impression that the perfusion was getting corrected with our intervention. But putting two and two together, the POCUS gave a little more revelations which we couldn't pick while it was evolving. So as I said, why we introduced this discussion in POCUS Plus segment, POCUS is a very useful tool for shock assessment. What we do here is assess the heart, IVC, Morrison spots, more useful for sepsis. In this situation, sepsis or hemorrhage as free fluid. Iota in adults, but here we can make it as iota because this is aortic stenosis, what eventually it was, where suprasternal view can be added in the POCUS itself, and the lungs. Lung fields can give whether the hemodynamic stability is because of CCF, there'll be B lines profile, or if there is pneumothorax, which is an obstructive reason for the shock. So shock, this is a rough way of running through the shock, and this is validated. This is the best tool for integrating for decision making as well as differentiating shock into 4 categories. So that is known to all POCUSians. But how POCUS Plus can additionally in this case could have made a difference? When we had a hyperdynamic heart, there was an assumption that it was volume depletion, dehydration. That was the trap. In reality, the hyperdynamic heart was pumping against the obstruction. Clear lungs, there was no CCF is the assumption, which was right, but then we know left-sided obstruction do not cause an early CCF. Persistent tachypnea, we still had, whereas the lungs was clear most times and revealed by POCUS also, mostly A lines, occasional B lines. What would that mean? It would mean metabolic acidosis. So metabolic acidosis or silent tachypnea usually is a clue for metabolic acidosis. When you rule out possibilities of metabolic acidosis, always keep in mind left heart, which is causing poor perfusion, is what causes metabolic acidosis and persistent tachypnea. Mild hepatomegaly could give either way clues. Narrow pulse pressure, again, that was a clue which we couldn't zero in on. As I said, when we have poor pulse pressure, we don't really attach much importance to the BP measure as a NIBP, but upper limb BP and the lower limb BP, when we are sequentially measuring fewer from the upper limb, fewer from the lower limb, had a lot of variations, and we assumed it to be because the perfusion overall picture is not improving. What actually in reality was the upper limb was 100/85. This narrow pulse pressure was again giving us information it was an obstructive phenomenon. So to differentiate between how it would be in a metabolic acidosis as how it would be left-sided heart, pure perfusion, tachypnea with clear lungs, you would see in both. Why? Because it's compensatory in acidosis of these reasons, or because of ischemic drive and the ductal dependent lesions. Hyperdynamic heart, again, compensation. This is fighting the afterload. Liver size can either ways be okay. We cannot have much differentiation there. Pulse pressure, it can be normal. Here, it'll be narrow. Response to vasopressor. This is again a trap. If this is the case, it might improve here because the steel phenomena, which the cardiologist was screaming in cases where it would make a difference, it will worsen. So this is one of the situations where vasopressors will cause a diastolic steel and worsen the situation. So these subtleties of POCUS Plus, so perfusion pattern, in a distributed hyperdynamic heart, when you have a hyperdynamic heart and it's not loss of volume, what one would think commonly hyperdynamic heart is when there is distributive shock. So a hyperdynamic heart with a full volume, if you do not have suggestions of wide pulse pressure, again, that's a clue that this is not distributive shock. So a duct-dependent obstruction will have a narrow pulse pressure. A blood pressure and pulse pressure will give those clues. Oxygenation clues, in the duct-dependent lesions, it will be differential. However, in our case, that was not the scenario because probably it was already closing ductus time. And in a distributive shock, it can be most of the times if it's poor perfusion, low saturation, and it will be distributive and it's not differential. Focus, how it can help, how it will not help. You cannot look beyond, if it's an hypodynamic heart, unless we correlate with other features, we probably cannot figure out what's going on. If we look for other clues, which I will show you, particularly the aortic arch view, which is not so much of a focus skill, but a neonatologist, all neonatologists are familiar with it. Although we are always urged not to go for the structural evaluation, it's a functional echo, what focus does. So still a little characterization of this could help if you know the skill. So the timeline also, if it is acute illness because of sepsis, it wouldn't be since birth the similar breathing pattern. So that would also be an additional clue. And if it's ductus dependent, as the closing happens, you will see more evolution happening. Response to interventions can be other clues. As we said, vasopressor will cause a gross downhill course, as well as fluids administration can cause either ways. Initial fluid would possibly be required regardless of what the situation is, but again will cause a similar physiology. So this would again give us just a snapshot. Focus may not give very useful information unless we integrate the additional physiology. So I'll run this again, although we saw it a couple of times. I see. The procedure is quite clear, visible. I would like the comments of the cardiologist on this. The descending aorta is not neatly, sorry. Okay, so if not to figure out what the lesion is, at least it will help us characterize decision making. Giving furosemide plus minus, giving vasopressors plus minus, would it help? Would it cause harm? Here, this would be a focus useful decision making. If you give a first, it's a trap, both interventions in situations. Furosemide, if you do not see the lung which is wet and a respirophasic IVC, it's a caution. If you do this, the hemodynamic stability will worsen. Same with vasopressor, we heard the first speaker speak. If you give vasopressors, increase the SVR, then the left to right shunt worsens, further worsening the situation, causing diastolic steal. So both these, when we have a metabolic acidosis kind of a scenario, that is a silent tachypnea, and we rule out all the other possibilities of silent tachypnea, and we do not have cardiac characterization and an hypodynamic heart, it would be safe to get on with a prostaglandin infusion with a 2D echo being arranged in the background. Additional things one can do would be, if you're checking on, I would like the input of the cardiologist here. If you have unequal chambers, left particularly small, the smaller chamber gives you a clue as the side of the lesion, which is possibly affected. This would be one of the clues. Doppler, we were navigating only the B mode. If you use the Doppler, you will see the flow, which would give additional insight. Here, if there are shunts and if there are valve pathologies, you would know if there is two views, the peel parasternal long and the subcostal will give you information of shunt and the direction of flow across the shunt. And this will help to comprehensively assess the situation, if not make a diagnosis of CHT, if it's a critical CHT with the flow direction of the shunt. Then you can use a suprasternal view, which is what I was talking about, which will give you a visualizing of the aortic arch and the flow across the aortic arch. If it at all, it can give you insight into coarctation of aorta. Other very useful thing that can be done is when we cannot really palpate the pulse and make an assessment of differential pulse, or the BP is not giving you useful information. This is a very simple, very easily, without much learning, can be done. Just use a probe to see the flow across carotid and femoral, and the pulse contour will give you information of differential pulse flow. So these are additional things that could have been done, that can be done with focus, if we have to characterize the physiology that we encounter in such situations. So I have the 2D echo images. Now I would like the input if our cardiologists can add information here. I gathered a few of these 2D echo images in the same case. Dr. Shweta, if you do not mind, I do not know if these images are very representative. I just pick the snapshots. I know clips would be more useful for your review, and I do not know if I picked the right ones. I'll just show you. This is the descending aorta. There is a flow that is seen, the power Doppler. So your comment, doctor, there is. I was under the impression if you visualize a descending aorta, it's good enough for what I can visualize. But the flow here would possibly give us more information, right? So
Right.
your opinion here?
So the first thing is sometimes it gets difficult to differentiate between IVC and aorta. So when you have flow coming towards the probe, you know you're identifying the aorta, and the aorta will be going behind the heart, whereas the IVC would enter the heart. Now, once we've identified the aorta, we may or may not see the color flow depending on how obvious or how good the cardiac output is. So what we do is we put a pulse wave Doppler. Now, when we put a pulse wave Doppler, I don't think my arrow will show, but yes, what you can identify is the usual Doppler across the aorta is pulsatile. It goes up in systole and then it comes down and touches the baseline in diastole. And you don't get a continuous forward flow in diastole. So this picture is very representative because first of all, you're not having a good peak. It's a very low amplitude pulse. And the second thing is that the flow is continuing all through diastole into the next cardiac cycle. So there is a continuous low amplitude Doppler flow across the descending aorta, and this is typically called as diastolic tailing. Even during diastole, there is forward flow across the aorta because during systole, all of the cardiac output was not able to make through the narrow orifice. So this is a very representative pulse wave Doppler of the descending aorta. Couple of points that I would like to add when we're doing an echo for a coarctation. This was an excellent case, very good illustration. We will sometimes get coarctation without the Schonz. So Schonz means left heart obstruction at multiple levels. But what if the heart itself is normal? What if the mitral valve is normal in size and it is only the aorta at the isthmus that is narrow, coarctation? So if you have a coarctation presenting in an older child or an adult, what you would expect is the left ventricle is having to pump against a narrow aorta. So it is a left ventricle that will become hypertrophied. So a coarctation echo in an older child will manifest as left heart enlargement. But this is in contrast to an echocardiogram in a newborn. Because in a newborn, all this while in utero, it was the right ventricle which was pumping through the ductus arteriosus into the descending aorta. And it is the PDA with its right to left shunt that maintains the cardiac output, and the PDA is originating from the pulmonary artery, which is originating from the RV. So a newborn coarctation will actually present with right heart enlargement, so the RV will be dilated. Secondly, in the suprasternal view sometimes, because in a coarctation the PDA is entirely right to left, it looks like you're seeing an arch. But that is actually the ductal arch. So many times a coarctation can be missed in a suprasternal view because the whole PDA is going to appear blue and people mistake it for the arch of aorta. So it is very important to differentiate between the two.
So thank you, doctor. So I'll just show some more images if they are good for your comments. I think this one is about
Having
the pulmonary
large
artery
PDA.
bifurcation.
Can I add something?
Yes, doctor.
Yes, please, doctor.
So having large PDA is actually very make coarctation of aorta fool anybody because it can be missed. Anybody can miss, even if you are expert cath. Even if you do cath, you can miss it with large PDA.
Right.
Because large PDA can be consequences of coarctation. So if you don't pick up coarctation and you have large PDA, that does not mean you don't know or you're not very good in, taking pictures. It's sometimes difficult for the best cardiologists. And sometimes even if three cardiologists meet, they can miss it. That's why sometimes there is indication for cath. So don't worry if, coarctation can fool anybody, including very expert people.
It did. This is pulmonary bifurcation. Would this be a comment on the ductus, doctor?
Right, so here,
And this is an arch.
yeah, I think even
Yeah.
the previous image was showing the PDA because if we can just go
right to
back
left.
to the previous slide, sometimes it can be difficult to differentiate between the left pulmonary artery and the duct. So the left pulmonary artery will be going here and the duct will be right next to it. And even the PDA will be blue. Usually what happens is the PDA is red and the left pulmonary artery is blue. But because this is completely right to left and the PDA is completely blue, sometimes we can miss it. But basically this is the duct over here in the parasternal short axis view. We would have to make sure that we're not mistaking one for the other, which is completely right to left. And in the next image, I think the left image over here was showing the left heart outflow. In this image, so how do we differentiate between the ductal arch and aortic arch? If we're seeing the head and neck vessels coming out, like on the image on the right side, so you can clearly make out the brachiocephalic artery and the carotid and left subclavian. So when you're seeing the arch vessels, you know that this is definitely arch of aorta, not the ductal arch. And over here, you can make out that the transverse arch is appearing entirely narrow. So this is very classical of a hypoplastic aortic arch.
So when you have this picture with mainly right to left, can I add something or I'm
Yeah,
not
sure,
cardiologist.
please.
Yeah. So when you see this picture, which mainly right to left, and even if you are not confused with the arch of aorta, you still need to worry because this is not the common presentation. It's mainly left to right rather than right to left. So if you have right to left mainly, then be careful that you have pulmonary hypertension. One, you might have systemic hypotension, very serious, and you need to consider, or you might have some extra connections outside the heart. So when you see this, which is totally right to left, and especially if it's more than 30% of the cycle, then you need to worry, even if it's not, if it's not, it's only the duct that's making not the arch of aorta. So please remember, pure right to left need a considerable consideration.
Thank you for that input, doctors. So this was the pulse wave Doppler across in the sites mentioned. Any comment on this? We can, the gradient, yeah.
Here we're clearly seeing, so this is not the type of pulsatile flow that you would see across the arch of aorta if it was normal. What we're seeing is it's going up in systole and then it fails to touch the baseline and diastole. It is continuing into the next cardiac cycle. So this is the typical diastolic flow pattern which we see in coarctation of aorta. So if we see a Doppler like this, suspect coarct.
Okay, thank you, doctor. Okay, that brings me to the conclusion. So as I said, the idea was to use focus and shock differentiation and how it could trap you and how neonates, it's not just assessing the preload, the cardiac contractility. There are additional players here, the shunt and the flow across the shunt and the transitional circulation. And that transitional circulation can dupe us beyond the actual neonatal period. This was a 5-week term baby, and this is how we encounter. And silent tachypnea, always, apart from the MISFITS acronym, silent tachypnea keep a ductus dependent cardiac lesion, particularly the left-sided and coarctation of aorta. So I conclude and I invite summarizing insights, some of which you already gave along with the 2D echo explanation from both the cardiologist and Dr. Yahya before we get on with the QA session. Thank you.
I'd just like to add a comment over here because we encounter a lot of drug-dependent systemic circulation in the NICU, and we start prostaglandin. And we may not always be doing the echo regularly, but it is important to keep in mind that we should not be overzealous with the prostaglandin and have an extremely large PDA. Because then we are creating an extremely large shunt, which is also deleterious. So, what happens is if you have a shunt, it will always follow the pathway of low resistance. You have a very large duct and a low SVR, then most of the blood that is coming out of the heart will go down to the descending aorta. The pulmonary blood flow can also suffer in this case, and the BPs will again start having a low diastolic. And again, this can be harmful for the baby. So it is very important to balance both the circulations. Duct-dependent systemic circulation just does not mean that we need a gigantic PDA. We need a PDA that should be just right to ensure cardiac output as well as keep the pulmonary blood flow going.
So, what additional physiological information will guide us here, doctor? So,
I think the diastolic pressure becomes important, the saturation, and if we have a mixed venous, nothing like it, because that tells us what is the peripheral oxygen delivery as well. I think Dr. Yahya was just about to say
Can I take 2 minutes?
Most resources, probably diastolic BP would be a good guidance.
Yes.
Thank you, Doctor. Dr. Yahya, your input here?
Yeah. So for the shock, we have the standard category, but also we have PDA associated shock in newborn babies. What I do is I diagnose shock, or I at least expect shock before the echo and before the clinical finding. Now, in human being, we have something, and I'm sorry, I want to make it very short. I have 4 publications on that, if you guys need to review it, about smart monitoring. So we have something called autoregulation. And autoregulation is the organ, the systemic organ, want to serve the master with the brain. So all the vital signs of the brain, all the physical output of the brain should be stable, should be centralized. Median, mode, and mean are all equal. Okay, and while the other organs should be scattered, should be lateralized. So what does not mean the heart goes up and down to save the brain, bowel goes up and down to save the brain, kidney goes up and down to save the brain. Once you lose this variability, then the body is giving up. Then the sign will start. This autoregulation starting to give up, it takes 2 to 24 hours before from the insult till the actual finding, whether it's an echo or clinical. So if you can pick these changes using smart monitoring, calculating the physiomarkers and the bathomarkers, including physio features and batho features, such as event-to-event variability, trend, rhythm, response to painful and pleasant stimuli, you can actually pick up these shocks before they occur, before they are clinically evident. And what I'm doing is I teach nurses how to do it. And I have laminated pictures, very simple, 6-or type. I say, okay, look at the monitors. This is do histogram, do point care geometry, do tachogram, do his frequency table. And these are the picture. Once you see this picture, and I do this every shift. So every 8 hours, the nurses look at the smart monitor and give it. So if they see compared to the picture, doctor, I have pattern, look at this picture. So what I'm doing, and I can pick up the shock-related PDA before it's actually appear in echo or before you can see it. That's called smart monitoring. So I would be very happy to present this one day. But if you guys interesting, if you can read, I write my name, and then you can see 4 publications about smart monitoring using physiomarkers and physio features. Thank you.
Would NIRS be the input there for the monitoring?
There's thousands of, so you have the heart rate, you have to event variability, you have cycle variability, you have value variability, you have rhythm variability, you have trend variability, and you can present in histogram, cumulative histogram, tachogram, point curve geometry, frequency tables. Then you convert it to picture, and here is where AI comes to give you the idea. Because human being can only process about 25 to 35 frames per second, while AI can process thousands of pictures. And here where AI can help you if your monitor connected to AI can actually tell you, oh, you're losing in the heart rate, you are losing your autoregulation. Just be careful, just assess. So that's what AI can help. And it's not fiction and it's not mythical, it's like science. Because event-to-event variability, cycle variability, value variability, trend variability, rhythm variability, a response to pleasant and noxious stimuli variability all can be measured. That's why we say it's smart monitoring, seeing beyond the visible. I'm going to give you an example. If I look at your face, I can see only 25 to 35 frames. But if there is a movement that is more than 35, we cannot see it. That's why when bullet comes, we don't see it because it moved 300 frames per second. So what if I put camera on your face and I make it 700 frames per second? Then I take one frame every 40, put them back, and then move them like a human being. Now I can see your face going red and pale with your heart rate, for example. Now I can see on your face things that I don't usually see. And that's what we call it smart monitoring.
Okay, doctor. The bottom line here is if there are any tools which can capture information before the irreversibility is kicked in, would be
Yes.
very useful.
Correct.
And this is what doctor is creating insight from hidden information from previous monitoring data that we possibly gathered. So, Dr. Shweta, I was just asking. So, autoregulation is the greatest pitch that dictates interventions and picking up before irreversibility actually happens. So, in that context, Dr. Shweta, how would you see NIRS and why it's not so common a place everywhere? In resource limitation, we don't really have it. So, is it expensive since it's giving us a real useful information? Why it's not so much of a standard of care?
So, NIRS, no personal usage in India. I did see it being used when I studied abroad for a little while. I think availability is the main thing, and it looks more at systemic organ perfusion, cerebral, renal. This would come in a little late, and I think we have at our disposal features that pick it a little earlier, is what my personal opinion is. Like echo is freely available in our centers, relatively easy to do, and POCUS and echo has a very high yield. So I think because we have more freely available and not expensive modalities available, that is why NIRS is coming a little lower down.
Okay. So this is
Dr.
for
Anita, if you don't have
structural.
NRSA, you can use others, heart rate, perfusion index. And if you combine and train people to use smart monitoring, it would be as good as NRSA, and it's very achievable. So if you start using smart monitoring for heart rate only, or heart rate and respiratory rate, for temperature, for blood pressure, whether invasive or non-invasive, and also for the perfusion index. Perfusion index is a great tool. So you can measure the perfusion index in the brain and non-invasive, and also in the chest, and compare it. And you can see that the perfusion index of the body, you put it on the lung or you put it on the bowel, on the kidney, you see it very variable. And you can see the perfusion index of the brain are very fixed. Once you lose that variability, it's a very good tool actually. And it's, believe me, it's as good as an RSA. And it's very achievable because it's your same principle. So you just look at it and try to use it. And it's very good for countries with limited resources.
Okay, so that summarizes a good physiologic integration of all the information that we have would support decision making. So apart from this case discussion and the useful insights I gathered from both the experts, we will go back to our webinar. Both the talks and the specifics, we didn't really go to the dilemmas of PDA. We will touch upon it few minutes in the discussion, and then go to Dr. Yahya, who was already overwhelmed us with a lot of information regarding the integration of AI in his domain. So, Dr. Shweta, Dr. Athar, let's open the question for the audience, for individual experts. And Dr. Athar, you can take the question and answer session. We will chip in discussion, please.
Most of the questions are asked in the comment box and replied also. One question someone asked, can paracetamol can be given for more than 3 days, like 5 to 7 days? Is it useful?
So yes, in our center, it varies, very individualized. So some physicians do use it for even up to 5 days if no response. The thing is with if you compare paracetamol versus ibuprofen or indomethacin, there is a little less efficacy reported with paracetamol, especially in the extremely preterm, less than 28 weeks. So if paracetamol fails to work, then maybe the consideration would be given to an alternative drug, or of course, then if depending on the clinical presentation of the child to closure. But usually it is 3 days, maximum 5 days. We do stretch it. It is a very individual practice.
So what I do
what's
is
the consensus? What's the first choice?
So personally, first choice 3 days, but I think I would like to have the opinion from the other experts as well.
Dr. Yahya will answer that.
So what I do, and again, I combine evidence with experience. Dr. Sweeta, and I hope that I pronounce your name correctly, gave us the hemodynamically significant. You have like a clinical, and you have echo finding to decide whether it's a clinically significant or not, and based on other like gestational age and weight. So what my practice is 3, 5, and 7 days. So I give for 3 days, and then I assess again, clinical and I use autoregulation. Very commonly I have autoregulation, then I'm not with treating. If I'm losing the autoregulation, that means your variability of your peripheral output is still there, not there. Then I go for 5 days, and then I assess 5 days. At 5 days, again, same. I go for 7 days and I assess. I never go beyond 7 days.
Okay. So any other questions, doctor?
The other question was answered already. Someone was asking contraindication of ibuprofen. Dr. Shweta already replied, bleeding risk, intraventricular hemorrhage. Then grade, there was question IVH, any grade. So for my understanding, grade 1, grade 2 of intraventricular hemorrhage is okay, but that also needs case-to-case basis evaluation why IVH happened. Dr. Yahya would like to answer that one. Someone is asking, giving Brufen with any grade of intraventricular hemorrhage?
So here is my goal with the ibuprofen and even indomethacin. They are very good on the PDA, but they are very harsh on the bowel and the kidney. So I usually, if I want to use them, I compare them with the paracetamol. So if there is IVH grade 1 and it's done on day 7, then I don't consider it. If it's grade 1 and done on day 2, day 3, I don't consider it. If it's IVH grade 2 and early, I don't consider it. If it's IVH grade 2 at 7 days, I consider it. If grade 3 and 4, I consider it. So let me summarize. Grade 1, whatever, and whatever, I don't consider it. Grade 2 early, I don't consider it. Grade 2 late, I consider it. Grade 3 and 4, I always consider it. To decide whether I go paracetamol or others. And when I go with paracetamol, it depends on the sickness level. If the baby is sick, I don't go more than 3 days. But in paracetamol, I go 3 days, 5 days, and 7 days. And also, I don't treat PDA, even if it's clinically significant. I only treat when it affects the management. So I'll give you an example. If baby clinically significant, but blood pressure is okay, baby ventilated, stable on ventilation, and tolerate feeding, then why should treat?
Exactly.
But if the baby difficult to ventilate, then I consider treatment. So having the input from cardiologists, that's only one face of the picture. And please remember that cardiologists only giving me the arterial side. They never give me the venous side. So having the smart monitoring, you can have the whole face. You have the tissue, you have the arterial side, you have the venous side, and you have the pump. Because cardiologists only give you the pump and the arterial side. They don't give you the tissue, they don't give you the venous side. So please remember that your blood pressure, your variability, your heart rate, your respiratory rate, your blood gas, your gaining weight, your feeding tolerance, your ventilation is soft, you're not deteriorating. These are all considered because remember, treating PDA or not treating PDA, the prolonged or long outcome consequence is the same. So yes, treating it very important, but sometimes remember, you don't need to treat it.
Exactly.
Yeah. He pulled in the dilemma part. Okay. So
Keeping us always
what
in the
is
gray
the
area.
decision maker? What is the decision maker? Is it the echo? Is it the clinical picture? Is it the trajectory? If echo and clinical picture are not hand in hand, echo is saying a very large PDA, whether the clinical picture is not, it is hemodynamically significant echo-wise, but then clinically not, the trajectory not, like the situations posed by doctor. So what triggers treatment of PDA in your experiences? A neonatologist is saying we do not treat, we wait, we process the trajectory. What does the cardiologist say?
It is very important to put together the clinical picture and the echo because neither can be taken in isolation. And it's always patient first. Whatever the echo might say, not just PDA, but even in any congenital heart disease, the treatment will always be determined by the clinical status of the patient. So I think that really comes first. And as Dr. Yahya has emphasized again and again, it's the basics which are important, the vitals, the trends, the variability, and how the baby is doing. That comes first. The echo always comes second.
So here what I do and how I collaborate with cardiologists. So first thing I say, I decide, is it PDA of prematurity, mean premature muscle, or it's a PDA because of structural problem, like a congenital defect PDA. If it's a structural, then I leave it to the cardiologist to decide. But if it's a PDA of prematurity, then I only take the input of cardiologist and I decide whether to treat or not. However, let's say if it's a PDA of congenital malformation, PDA associated with rubella, or PDA with malformation, or PDA with other structural problem, I usually follow the cardiology recommendation. But only PDA of prematurity, I take the input, very vital, take the input of the cardiologist. But I consider, as Dr. Sweeta was saying, I consider the clinical, baby softly ventilated, baby tolerate the feeding, gaining weight, not edematous. A urine output is okay. Lactate is okay. Perfusion index is okay. Baby is sleeping overnight. Pain score is okay. Why I should treat? Even if the PDA is big, I don't treat. So cardiology is a structural. Neonatology, we go with functional problem. So here how I approach the PDA.
Yeah, that completely brings in the dilemma part of PDA. Thank you, doctors. Let's bring in focus to the gray zones of neonatology. Are there any questions there?
There was one question regarding antibiotic. Dr. Yahya already explained in detail in the message whether to give ampicillin. Someone asked whether.
So the question is, sorry for interruption, but the question is whether we use ampicillin, gentamicin, or cefotaxime with gentamicin. So both are okay. But why I do and what I do is first we need to differentiate between rule-out sepsis and sepsis. There are two different identity, two different ICD code. So rule-out sepsis is when you have symptoms and you have risk. You need to rule out sepsis because you're confusing it with other diseases. So what is the best? Now the best scenario, is ampicillin and gentamicin. The reason is they are cheap, they are synergistic, they are broad spectrum. Gentamicin is good on staph. Ampicillin is good on strep. Ampicillin only work on the most medications that work on listeria. So for rule-out sepsis is very good. However, if the baby is outborn and come to you, then it's community acquired will be associated. Now you need broader. You need to cover more gram-negative. And whether to use cefotaxime if the baby outborn with gentamicin or amikacin. I use amikacin and cefotaxime when the baby outborn. The reason is because outborn usually is resistant to gentamicin. Not always, but there is a good percentage that is resistance. That's why ampicillin and gentamicin, in my opinion, superior to cefotaxime and gentamicin. And if I decide to use cefotaxime for outborn, I combine it with amikacin.
Thank you. So, certain more questions. What's your opinion about culture negative sepsis? Would that be a concept, or would you?
Yeah, so here how I do it.
There is no ICD
How
code
I
for
do
it.
Yeah, I know. Now, remember that the culture negative sepsis is 30%. Okay? So here how I assess the unit, overusing antibiotics or not. Let's say that unit have 10 beds. Okay? And they have 5 babies at a time on antibiotics. Because the culture negative is 30%, so 30%, then 70% of these should have culture positive. So let's make it simple. 10 babies on antibiotics. If you're giving 10 babies antibiotics in your unit, you should have 7 babies culture positive. Otherwise, you're overusing antibiotics because we know culture negative sepsis is 30%. Let's say 40%. So 4 should be negative and 6. If you're using 10 and you have less than 6 culture positive, then you're overusing antibiotic. So that's one. Second is I always do sepsis workup or rule out sepsis. A rule out sepsis means CBC, blood culture, antibiotics, whatever the course you're using for 48 hours. Now, if the culture is negative or no report, because we depend on something called yield, which is the percentage of possible positivity. The yield at 6 hours, culture negative, is almost 80% possibility of culture positive. At 24 hours, it's a 50%. At 48 hours, it's about 75%. So you still have a 25% possible positive. But if you combine it with the clinical, lactate is okay, blood gas is okay, urine output is okay, sugar is okay, baby tolerate feeding, but still the baby ventilated, then the likelihood that you have positive is less than 5%. You will never have 100%. But what will happen if you stop antibiotics? Baby deteriorate, do another culture restart. But you save baby. Remember that antibiotics will change the antibiome, not only for the baby, but for whole unit. And the antibiome is very good for a future program because you're changing the whole physiology of the body. So there will be consequences the whole life of you for using antibiotics. So it's very important that if you have symptoms and you have risk, then rule out sepsis. If you 24 hours and culture negative, but still you have a problem, then you go for 5 days, repeat the culture at day 4, day 2 and day 4. And if 2 culture is negative, then you don't need antibiotics. And remember, please, that culture negative sepsis is only 30 to 40% of whole sepsis. You cannot have 10 babies on antibiotics and all you say, oh, this is culture negative sepsis. That is incorrect practice because remember, antibiotics change the biome. It reprograms the body. It's like carrying the baby from the leg. That's the practice. The Indian movies, the Egyptian movies, the Hollywood movies, you carry the baby and the baby has to cry. The baby does not need to cry. The head always above the body. So because you carry the baby from the leg, you cause pain the whole life. You cause bag egg. You don't know that, but that will happen. Same for antibiotics. When you use antibiotics for a long time without a reason, you are reprogramming the body. You're changing the flora. And reprogramming the body is changing the whole body physiology, the brain, the heart, not only the bowel. So please remember, culture negative sepsis is only 30 to 40%. Don't overuse. There is risk and symptoms, rule out sepsis, repeated culture. And remember, inflammatory markers is only confusing, because I will tell you, if you're single and not married, your
next
inflammatory
question.
marker is high. It doesn't mean that the baby has high markers, it's a sepsis. So the inflammatory markers help in two areas only. One, it's negative. That means definitely there is no infection. Two, it's rising. So if it's rising and culture negative, I go for 5 days. If it's going down and culture negative, I stop the antibiotics. So if they are sequence rising or sequence down or negative, it helps. Otherwise, it does not help. Whether you have CRB 60 or 5, it doesn't mean anything. Sorry, I'm talking too much.
My next question about role of inflammatory markers, particularly procalcitonin. So you answered that already. Now the question about repeating cultures in the pediatric sepsis and adult sepsis, unless certain organisms like Staphylococcus aureus and Candida may be gram-negative.
So
it is not a
repeating culture
recommendation.
I do a repeating culture if positive, if culture is positive, and it depends positive, gram-positive or gram-negative.
Regardless of the
I keep
organism.
repeating every 48 hours until I have 2 culture negative and I finish the course. So if it's a strep, then I go for 7 to 14 and 2 culture negative, I stop antibiotic. If it's a gram-negative, I go 21 days and 2 culture negative. So I keep repeating until I get 2 culture. Now, if it's the culture negative and the baby is symptomatic, and I do have risk factors such as leukocyte less than 5,000, I repeat the culture. If I have 2 culture, the first one and second one negative, even if the baby keeps symptomatic, I stop the antibiotics.
Okay. But if there is no response, you will consider it as resistance and follow suit.
Correct.
That's clear. That's for the audience perspective. I just summarized it. So, but then as I was saying, unless specific organisms, only the recommendations go for repeating the cultures and just finishing with the course without repeating. If clinical resolution parallel, it is not a recommendation anymore.
I have 45 minutes talk on YouTube on sepsis. I have another 45 minutes talk on inflammatory markers. Anybody interested, go to my YouTube channel and listen.
Thank you. Thank you, Doctor. So any more gray areas you want to touch upon, Dr. Athar?
There was one question, preterm more than 28 days with persisting PDA given 2 times paracetamol, will it be useful again?
Is that the cardiologist or me?
Both of you, maybe? First cardiologist.
Let's go with the cardiologist.
So now we're talking about a more than 1 month old child. Of course, gestational age also makes a difference, but we've already treated and there's been no response. I think depending on how significant it is clinically, I would probably refer for intervention rather than giving another course of paracetamol.
In your experience,
how I decide.
Yes, Doctor.
Can I say?
Yes.
So here how I decide. First, if it's 30 days and not responding, most likely this is not PDA of immaturity. So most likely you have structural problem. It's not immaturity of the muscle. You have either abnormal or dysplastic muscle. So treating it by medication will not help because it's mostly structural. So now you decide to close it or not, depending on the clinical context. If you decide to close it, then you have 2 approaches, surgical or non-invasive, like by cath. So this is how I decide. Depend, if you have a PDA and you don't have heart failure, you don't have evidence of dilated left ventricle, other finding of the echo, the disturbance of the flow in the aorta, and so on. But also, your baby is growing. Your baby is not ventilated. Your baby is peeing. The sugar is okay. Lactate is okay. And you're gaining weight. Why you treat? Don't treat. You treat only when you have consequences. Now, if it's 1 month and you decide to treat, then it's not medication. Unlikely to respond. Then you leave it to the cardiologist to decide to close it by cath or surgical.
Thank you. This is about for the pediatrician information as to what to choose and when to choose. Now I'll just change the direction of discussion to Dr. Shweta. So what is you did discuss about the pros and cons of interventions, and the interventions that you get would be possibly deciding beyond the medical intervention, which the neonatologist's first choice. Your choice would be to the cath and the surgical. What are your common choices, and what is your experience and the outcomes with your experience? What's the choice? What's the outcome?
So until lately, it was always surgery. Because it's relatively simple to do, and no cardiopulmonary bypass involved. The baby, usually if it's a hemodynamically significant PDA, is already on the ventilator. There's not much extra that needs to be done, and it is a relatively simple procedure for the surgeon, of course, with the risks mentioned. But recently, the trend has been to move more and more towards transcatheter devices. At our center, we've not done many, but yes, we have done preterm piccolo, approximately around 1 kg weight. Like I mentioned, more than 700 grams is when it would be tried. But I think there are centers which have tried for extremely low birth weight infants with good outcomes, except that the left pulmonary artery can get stenosed. So that is something that we need to look out for. And it depends on the expertise of the center also. So, but it is extremely getting more and more common for low birth weight infants to get transcatheter device closures, with a lot of advantages, because we're bringing down the incidence of infection, and there is growing experience in this.
Thank you. Thank you, doctors. I think we can wrap it up. Any passing closing messages, both the doctors? You can just go ahead and give us our closing remarks before we wind up. Dr. Shweta first.
Yes, I will leave the closing remarks to Dr. Yaya. I just want to say that it was a very good session. I loved the cardiac case that you presented, also interesting. Sometimes we will go ahead and close the PDA and not realize that there was a coarctation shelf before the duct. So it's very important to look for it on echo as well. If you're seeing a posterior shelf, before we close it, we have to be extremely sure this is not a juxtaductal coarctation. So it can be, a risky situation. So it's good to get a good echo before you actually go ahead and do medical management or any form of management of the PDA. And excellent session. Enjoyed being part of it. Thank you.
Thank you.
Thank you, Doctor. Dr. Yahya.
Thank you very much
You are
for the
first.
invitation. They always tell me I'm a dominant, so I speak a lot. I hope that I didn't bother anyone.
It was very welcome, and we gathered useful information in the passing discussion more than from the presentation. It was very welcome. Thank you.
Thank you very much.
Any
And
passing
I was
messages
very
you want
happy
to give
listening
us?
to Sweta.
Yeah.
Thank you. Dr. Attar, your closing remarks before I pass it on to Dr. Mohammed.
Dr. Mohammed?
Yes. Thank you for both speakers. I think it's very informative and interesting session today. The discussion is very useful. The only thing that always the neonatology keep me, there is no black and white. So it is always the babies in the gray area where we need the professional, the expert, and the teamwork. It's not the decision of the cardiologist or the neonatologist. I think the teamwork, which is looking for the whole baby condition and to get the final decision for the treatment. Thank you, Dr. Yahya, and thank you, Dr. Monti.
Thank you very much.
Thank you,
Thank you
Dr.
all.
Shweta, Dr. Yahya, Dr. Attar, for your expertise and very interesting session today. And looking forward for more interactions with both the experts in our daily practice. That's as I close in, I always say this is the additional perk. Interacting with you gets us contact about any future needs. We can count on your expertise for our decision making. Thanks a lot. Signing off. This has been thanking all the participants before I sign off.
Bye-bye.
Thank you for
Thank you.
signing in
Thank you.
on
Thank you.
Sunday.
Thank you.
Thank you all. And this
Thank
session
you.
is recorded and will be available for your viewership later. Also, those who missed the session. Thank you very much. Bye.
Thank you. Bye-bye.
Thank you.